surgeryandmedicine.com, your med school in your pocket.
Welcome to the video podcast about fistula in ano. This podcast is aimed mainly at medical students, though it may be useful for newly qualified doctors or even people revising for postgraduate qualifications such as their MRCS as a basic reintroduction to this topic. Firstly, definition. What's a fistula? A fistula is an abnormal communication between two epithelial surfaces. Today we're going to talk specifically about fistula in ano, or anal fistula. What causes anal fistula? Well, there are a few causes. The most common cause is cryptogenic, where the infection starts in a gland and then becomes a fistula, and that's what we're going to concentrate on later. I'm going to explain that quite carefully with the aid of a diagram. Other things that can cause fistula is Crohn's disease is not an uncommon cause. It can cause fistulation around the anus, and also more rarely cancer and obstetric trauma. So what we're going to do now, I'm going to draw a diagram and we're going to talk about cryptogenic fistula in ano. Okay, so what I'm going to draw for you first is the anatomy. So what we have here is the rectum, the anal canal, and the skin of the buttocks. Around the anal canal, two sphincters. Imagine these come all the way around. So the internal anal sphincter, the external anal sphincter, and then the levator ani muscles, pelvic floor, like this. Now, most fistulas are associated with little glands that are situated in here, between the internal anal sphincter and the external anal sphincter. And these glands empty into the anal canal around the level of the dentate line. There's about a dozen or so of these glands. For some reason, what can happen sometimes is some infection occurs in that gland. So what patients notice is that they feel discomfort, and the infection comes out towards the skin, presents as an abscess in the perianal skin. The patients come into hospital and have this abscess incised and drained. Now, about 90% of perianal abscesses settle with incision and drainage, but about 10% something happens and this either the abscesses originate in the skin, or the sepsis here hasn't quite drained properly. And so what patients experience then is that more pus will gather in that gland. They'll feel a feeling of discomfort and pressure, maybe some pain, and then as that discharges, they'll get a bit of discharge and the pain settles down for a few days. So what patients tend to experience is a cycle over a few days of discomfort, pain, followed by discharge, followed by a period of comfort again, and everything's back to normal, and then the cycle repeats itself. And so they get a repeated discharge from the site of where the abscess was. After time, this happens again and again, and this track becomes established. And so with the duct from the anal canal through the gland to the outside, what we have now is an abnormal communication between this epithelial surface here and this epithelial surface here, or a fistula. Now, these tracts can develop in all sorts of ways. The tract can develop down here to the outside, so-called intersphincteric fistula, or come across the sphincter, a transsphincteric fistula, and that can be either reasonably low down or occur higher up, and so you have much more of the external sphincter involved, and we'll talk about that a little bit more in a minute. Or very rarely, fortunately, the tract can extend up here and become a superlevator collection, which is very difficult to deal with, but fortunately it's pretty rare. So how do we treat these fistulas? The all depends on draining this collection of pus in here. If the tract is low, so this one here, the intersphincteric one, so it only goes across a bit of an internal sphincter, or across the lower third or so of the external sphincter, then the best way to do it is to put the patient off to sleep, do an examination around anaesthesia, put a probe along here, and then cut down onto the probe, scrape all the gunk out of the tract, and then leave it to heal by secondary intention, so it heals by itself with or without packing depending on local preferences. And this is called laying open of the fistula. And that sorts out most fistulas, although you must always warn patients that sometimes it takes more than one or even several goes to get these things right, because fistulas can extend elsewhere. You don't quite pick that up on the first examination, or can horseshoe round behind the anal canal and have quite complicated tracts. So for lower fistulas that don't involve much of the sphincter muscle, we can lay them open. But of course we've cut across the sphincter muscle, and so we've injured it, and so that impairs continence to some degree. And the more of the external sphincter in particular we divide, the greater the risk of incontinence following surgery. So when the fistula tract is higher and goes across much more of the external sphincter, then what we don't want to do is to open all that up, drain the sepsis, but leave the patient with a problem with continence. And so what happens again is the patient's given an anaesthetic, either a regional anaesthesia to block around the anus, or a general anaesthetic. The tract is explored, and then this part of the tract on the outside is removed. Often this part on the inside is opened up, but to preserve the external sphincter, a piece of material, sometimes a silk tie, sometimes a vascular sloop, is passed through this tract and is either left very tight or reasonably loose in order to drain this sepsis here. And this is called a seton, which is an old English name for pig's bristle, or actually horsehair I think, rather than pig's bristle. And it's a very, very established treatment going back many hundreds of years. And what this allows to happen is for the sepsis to drain here and everything to settle down without actually cutting across the external sphincter. Later on, the seton can be removed, and sometimes the internal opening here is then closed by advancing a bit of tissue either from the anal canal downwards or the anal skin upwards, depending on preference, to close off the internal opening once the sepsis has been drained. Sometimes people put in what's known as cutting setons, and this, where the seton's tied very tightly and it causes pressure necrosis of the muscle, and the patient's brought back repeatedly for tightening of the seton at intervals, and the seton slowly cuts through the external sphincter, perhaps draining the sepsis, with the sphincter healing by fibrosis, so the muscle doesn't come apart as if it would if it's suddenly cut, but heals behind it. It's a bit like that experiment in chemistry A level where the wire cuts through the block of ice without actually, and the ice freezes behind it, so the wire passes through the ice, leaving the ice intact, if you remember that. It's very similar to the cutting seton. No one really knows which of these is best. A lot of people now prefer to use loose setons just to drain sepsis and then do something about the internal opening later. But opinion is still divided. There's no great evidence either way. So, in a nutshell, that is talking about fistula in ano. If you have recurrent fistula in ano, the thing to do is to organise an MRI scan, which will show you if there are any tracts that have missed, any horseshoeing, or any abscess cavities that are still keeping the fistula going that you haven't picked up at your initial examination and anaesthesia. So to summarise, fistula in ano is a relatively common problem in surgical outpatients, so colorectal surgery outpatients. A fistula is an abnormal communication between the two epithelial surfaces. The causes can be this cryptogenic cause, Crohn's disease, or more rarely cancer, and obstetric trauma, and treatment depends on laying open or draining this the sepsis. In Crohn's disease, it depends on getting the underlying disease better. In cancer, obviously, you need to do something about the cancer if you can. And when treating the cryptogenic fistula in ANO, do have to be careful about continence and not causing undue damage to the external sphincter when deciding whether or not to lay open the fistula or to put in a seat on.